Hello and welcome to EHA Unplugged.
So, good afternoon. I'm Herman Einsele. I'm based in Würzburg in Germany, and I'm the director of the Department of Internal Medicine at the University Hospital in Würzburg. So, my topic is multiple myeloma. And fortunately enough, we have now 2 commercial products that are available for our patients in fourth-line therapy, and these patients have to have received already proteasome inhibitors, IMiDs, and anti-CD38 antibodies. For this patient cohort, the prognosis is very poor, so only about 30% of patients are responding to any other treatment, and the median progression-free survival is less than 5 months. So it's really an unmet clinical need. And for these patients, we now have these 2 CAR T-cell products available. The first one is ide-cel, which is a BCMA-targeting CAR T-cell product, which was approved according to the so-called KarMMa study, in which 140 patients were included. They had a median of 6 lines of prior therapy, including quite a lot of patients, nearly 40% with extramedullary disease. In the approved dose rate, we had an overall response rate of 81.5%, nearly 40% achieved a complete remission, and we have a median progression-free survival of 11.3 months. In patients that achieved a complete remission, the progression-free survival was beyond 20 months. And fortunately enough, and that's quite a difference to patients receiving CAR T-cell therapy for lymphoma, the severe grade 3 CRS and neurotoxicity was rather low, 5% CRS grade 3, 3% neurotoxicity grade 3. The second product that is now also commercially available is cilta-cel. This was studied in the CARTITUDE-1 study, and impressively, also these patients had 6 lines of prior therapy, slightly less patients with extramedullary disease, 40% were actually penta-refractory, and even these patients had an extremely high overall response rate for 97.9%, so more than we can actually achieve even with frontline therapy in a patient with multiple myeloma. 82% achieved a complete remission, and the median progression-free survival is not yet reached and is clearly beyond 27 months. What we know is that specifically patients that achieve an MRD negativity and obtain sustained MRD negativity do extremely well, and probably most of these patients are still progression-free after 2 years. What we know is that patients with extramedullary disease have a lower likelihood of developing MRD negativity. Now, what are the problems? The problems is still we don't know whether we are really getting long-term disease control. And one of the issues is that the persistence of the CAR T-cells is limited. So what we are currently doing, or what researchers and industry is doing, that they are generating a CAR T-cell product with a longer persistence, and these are mainly CAR T-cell products that contain a higher number of memory T-cells. And one of these products was actually tested and first data presented at the ASH meeting, clearly showing that with a lower number of patients, they were still able to achieve 100% overall response rate, 70% complete remissions with a rather low toxicity. So this is one step. The other further developments is to move CAR T-cells to earlier lines of therapy, because we hope that then the T-cells will be fitter and the tumor cells more immunogenic. And at least the first data from the KarMMa-2 and the CARTITUDE-2 trials seem to support this. Again, an extremely high overall response rate, high number of complete remissions, again going into nearly 90% of some of these patients that had an early relapse following autologous stem cell transplantation. And the next step is now to move CAR T-cell therapy to first-line therapy and to challenge autologous stem cell transplantation in first-line therapy. In the more later lines of therapy, we see now also patients that are losing the target antigen on the myeloma cells. So we have an increasing number of patients being reported with a BCMA loss, which is due to an irreversible deletion of a part of chromosome 16p, which leads to the loss of the gene that is encoding for BCMA. And because of this, obviously BCMA targeting is no more sufficient and effective in these patients. So we need additional targets, and we have new targets. So GPRC5D, there are 2 products now in late clinical development. We in Würzburg are doing a study with SLAMF7 CAR T cells, so we have different targets. But again, for example, for GPRC5D, we also have seen now patients that have a loss of GPRC5D. And that means that we need additional targets that probably similar to the CAR T-cell therapy in lymphoma and ALL, we're moving into dual targeting or maybe even triple targeting to prevent target antigen loss on the myeloma cell. And furthermore, combination therapies is extremely tested. So tyrosine kinase inhibitors, IMiDs, CELMoDs, or immune checkpoint blockers are explored in a combination with CAR T cells to increase the persistence and to improve the efficacy.